Welcome to the Office Hours Quality Payment Program, QPP, conference call. My name is James, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the Q&A session, if you have a question, please press star 1 on your phone. And I'd now like to turn the call over to Mona Matthews. Mona, you may begin.
Thank you, James. Hello, everyone. This is Mona Matthews. I'm a project specialist with the Lake Superior Quality Innovation Network serving Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this session of the QPP office hours. Today's call will be operated assisted. By default, everyone's phones are currently muted to avoid background noise. Since this is an open office hours call, there will be opportunity to ask questions over the phone, at which time our operator, James, will provide instructions. We will also be closely monitoring the chat box and encourage you to post questions or comments throughout. Also, please note that the information provided in this session is based on the latest information made available by the Centers for Medicare and Medicaid Services and is subject to change. CMS policies change, so we encourage you to review specific statutes and regulations that may apply to you for interpretation and updates. At the end of the office hours, you'll have the opportunity to complete a brief evaluation. We would appreciate your feedback about this event and suggestions for future educational opportunities. We'd also like to remind those of you that receive direct technical assistance related to the QPP to please take time to complete the evaluation sent at the conclusion of each technical assistance encounter. Your feedback is very valuable to us and helps us to gauge how we are doing in regards to meeting information needs in a timely and courteous manner. The last reminder, I'd like to mention that during the office hours, we can typically address a broad range of questions which are based on equally broad range of QPP NIPS knowledge level of our call participants. Some questions we'll be able to answer quickly. Others may require some additional time to research due to the complexity of the question, while others will be scenario specific to your organization. Our team has implemented a process to capture all the Q&A presented during this call. Questions that our team deems broadly applicable to all in our audience will be emailed to the participants within 2 weeks of this event. Those that are scenario specific, our team will address directly with attendees via email or by phone. Finally, questions that require more research or those that appear frequently will be addressed at the next office hours. Today, our objectives, we just want to provide some quality payment program updates and new resources for a successful participation in reporting. I'm going to summarize a few important deadlines and provide an opportunity for questions and answers. So some important deadlines. January 22nd is the window will open for the MIPS payment or data submission period for those of you that are using the CMS web interface. And March 2nd, 2018 MIPS claims data submission closes. March 22nd, the CMS web interface data submission closes. And on April 2nd, the MIPS data submission period for 2018 closes. Today we wanted to just do a little bit of a deeper dive into the category of the promoting interoperability. So there have been a few changes in this category for 2019. So some of the things that didn't change with this category is that the weight continues to be 25% of your total MIPS score. And also the minimum reporting period remains the same for 90 days, which is 90 days. And that is the minimum reporting period. You can report anywhere between 90 and the full year, but you do have to submit at least 90 days. Something that did change for this year is you must use the 2015 electronic health record or EHR technology. And also changing this year is the new performance-based scoring, which I'll review a little bit here in the coming slides. And in the past, if you remember, this category used to have a potential of 150 category points. Starting in 2019, there are 100 total category points with some bonus points available for this category. So with that, so just kind of reviewing what you need to do to receive any points in the promoting interoperability. You do have to use certified EHR technology or CERT for the performance period of 90 days or greater. You do have to submit yes to the following statements, which should look pretty familiar to most of you. You do have to submit yes to preventing information blocking and to the Office of National Coordinator Direct Review Attestation. And you also have to complete a security risk analysis, which is part of the promoting interoperability category. And you have to report the required measures under each objective or claim the exclusion if applicable. So a little bit about the performance-based scoring at the individual measure level. Each measure will be scored on performance for that measure based on the submission of a numerator and a denominator or a yes-no answer. The scores for each of the individual measures will be added together to calculate a final score. And if an exclusion is claimed, those points will be allocated to other measures in the category. So just a little bit of a review. For some, maybe this is new to others, but the objective and measures are listed on this screen, and I'll review each of them. First, e-prescribing is worth a maximum of 10 points, and there are some bonus points available under this particular measure, objective and measure. The first bonus point, which is worth 5 potential points, is querying the Prescription Drug Monitor, or PDMP, and verifying opioid treatment agreements. Both of those are worth 5 bonus points. Health Information Exchange has 2 measures attached to it. The first is to support electronic referral loops by sending health information. This was formerly sending the summary of care. And the potential points here are 20 points. The second measure under this objective is to support electronic referral loops by receiving and incorporating health information. And this is new this year. And the next objective is to provider to patient exchange. This is your patient portal. So this is to provide your patient electronic access to their health information. The potential points are 40 points here. And then the last objective is public health and clinical data exchange. So listed here under this measure are things like immunization registry reporting, electronic case reporting, public health registry reporting, clinical data registry reporting, and syndromic surveillance reporting. And the potential points here are 10 points. Sometimes when we look at these different objectives and measures, it might be helpful to look at a scoring example to see how the scoring works for this category. Remember, the scoring is performance-based. So last year, for those of you who reported, will recall that there were some base measures and then there were performance measures for you to participate in, and you had to get the base measures to score any points in this category. This year it's moved to all performance-based measures. So that first one, e-prescribing, as I mentioned in the previous slide, is worth 10 points. So in my scoring example here, the clinic or clinician that submitted this data had 200 out of 250, which calculates to a performance rate of 80%. So the potential points are 10, so you just take 10 times the 0.8. So on that particular measure, this particular clinician or clinic is scoring eight category points. And you can see down the line here how that works. The calculation is basically the same for each one. You add up the total points received for each of these, each of the objectives and measures. And in this case, we're giving this clinic or clinician 78 category points for their data submission. And then when you take that total score of 78 points, and that's 78 out of 100 possible points, is what this clinic or clinician received. So then you have to calculate the contribution to the MIPS final score by multiplying it by the 25% weight, which that calculates to 19.5 performance category points. And the final performance category score here would be 19.5 out of the 25 performance category points. So the reweighting, there are some reweighting that can happen with this particular category. Some of the same requirements as year 2 with the following addition. The new clinicians that are eligible this year can all get a automatic reweighting. Now remember, if you're a clinician or if you have clinicians that fall under this automatic reweighting category, you do not have to file a request to have it reweighted. So the physical therapist, occupational therapist, clinical psychologist, speech and language pathologist, audiologists, and your dietitians and nutrition professionals all will have this category reweighted if they do not submit any data. So some 2019 changes just to summarize. Eligible clinicians must use 2015 edition CERT. Elimination of the base and the performance and bonus scores. There's a new scoring methodology, which we just reviewed, and one set of objective and measures based on the 2015 edition CERT. And clinicians are required to report certain measures from each of the 4 objectives, and adding 2 new measures for e-prescribing. So this slide highlights some of those changes. So that's what I had for a review of the PI category, and I can open it up to questions at this time. James wants to open up the line so that people can ask questions.
Excuse me. We can now begin our question and answer session. If you have a question, please press *1 on your touchtone phone. If you wish to be removed from the question queue, you may press the pound sign or the hash key. There may be a delay before the question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. So once again, if you have a question, press *1 on your telephone. Well, it looks like we have no questions.
Not seeing any in the chat either. You can post your questions in the chat, and we'll watch for those as well.
And we do have a question just come in from Ben.
Yeah, hi, thanks. I'm new to the MIPS world, and I submitted first time for this practice at the claims level, so it was a claim-based submission, but that was a very tedious project, and I was just hoping to get some resources on what other methods are out there, and if there's any particular companies that you guys have worked with that are, that you can refer me to that do this type of thing.
Ben, what state are you from?
Minnesota.
Minnesota. I think I would probably encourage you to reach out to Stratus Health to start with.
Okay.
And are you on the WebEx right now?
Yes, I am.
So on the slide that I have on the screen right now, there's an email for Candy Hansen, who's the program manager there. That would be a great place for you to start.
Okay, perfect. Awesome. Thank you so much.
Yeah. You're welcome. And any other questions we can help you with?
Once again, if you have a question, press star 1. And again, we have no questions.
All right. We do have one question in the chat. It's a rather long question. It has to do with being a tribal, because we are a tribal site in Carleton County, Minnesota, and would like to know if we would be able to take the exclusion for Objective 5, patient electronic access to health information. Any EP that conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its houses having broadband. Okay, so they're stating. I would have to look at that, and I know Reed is also on the line, but he put it into the phone number instead of on the line, and he's our person from Minnesota. We can look into it, but if you want to dial in and maybe offer some.
We do have Reed.
Okay, all right.
Yeah, hi, can you hear me okay? This is Reed at Stratus Health.
Hi, Reed.
Great, we are connected. So, yeah, certainly the prior caller, Ben, will get connected. I work along with Candy Hansen so we can address your question. And then with regard to this current question here, it pertains to the provider-to-patient exchange. I believe that's what's being asked here. And I was actually pulling up the specification sheet. These just came out in December, on December 27th, and there actually isn't an exclusion for this, but I certainly understand, and that was in prior iterations of both meaningful use and MIPS, that there was some consideration as far as like connectivity to the internet, and that was also true for e-prescribing, anything that you had to do electronically. I think we'll have to do a little bit more digging because on the specification sheet itself, I'm not seeing that immediately, an exclusion based upon ability to connect. And of course, they're making the assumption that if you're using CERT, you have some level of connection, but we know that's not always true. So, unfortunately, I don't have an immediate answer.
Reed, a follow-up to that, would they be able to file a hardship exemption?
Yeah, there is the PI category hardship exemption. And also, just since you brought that up, a little aside, I was just working with a clinic that had a question about that for the 2018 recording year, and they were wondering as they go in and submit their data, they hadn't heard back from CMS about their hardship exception and wondered what to do. And the advice that I was given to share with that clinic was to go ahead and have them report. And although they wouldn't be submitting PI category data, they wouldn't see the score change. And those were they apparently had a lot of applications. The department at CMS is addressing those, but they would see an inaccurate total score for MIPS when the time comes. They still wouldn't see any changes when that closes on April 2nd, but that would then be changed after that time. So the advice was go ahead, submit your data, and you'll see the score change after the closing of the reporting period. So that was the current advice that the CMS Help Desk provided.
Thanks, Reed. All right. I do have another question in the chat. I got to scroll down to it here. Lost it. For the newly eligible clinicians such as PT, do they need to opt in or are they automatically included in MIPS? That's a really good question. If they meet all three low volume thresholds, if they exceed those low volumes for all three, they are required to report. If they do not exceed, if they exceed one or two, they can opt in to report. Now that's either at the group or the individual level. That would, if you report as a group, those low volume thresholds are applied at the group level, and if you report as an individual, they are applied at the individual level. If that doesn't answer your question, feel free to chime in and ask it over the telephone. I think I got that right.
And Mona, this is Reed. If we don't have any additional questions, I could add to what you said about the PI category and objectives and measures as they had gone through the specification sheets and found some interesting insights as to some of the details that folks might want to hear about.
Okay. Well, I do have one other question.
Let's do that.
Well, a couple of questions came in now. It says just to confirm, the clinical information reconciliation measure, MedRec, is no longer included. That is correct. The measures and objectives we reviewed are the ones that are included. And then also, will the slides be made available? The answer to that is yes. Okay. That's all I have. Reed, you want to?
Sure. One thing I wanted to point out was that we talked about reallocating through a hardship exception the entire category of 25 points over to the quality category. CMS has taken that approach and also applied it to exclusions for particular objectives and measures within the PI category and reallocating those points. And Mona, if you were able to flip back to that chart where it showed the points per measure, that would be helpful there.
You want the example?
There we go. Slide 8. Yep. So for e-prescribing, there is an exclusion for e-prescribing if you have less than 100 prescriptions in the measurement period. And in the specification sheets, CMS says that they will reallocate those points to the HIE, Health Information Exchange, measures there, and they will divide that 10 points into 5 each, so you would end up with 25 each instead of 20 and 20 for those two Health Information Exchange measures. If you went further down to Health Information Exchange, and let's say that you couldn't complete that send a summary of care, there's an exclusion if you have fewer than 100 referrals or new patients within the measurement period. They actually haven't determined how they're going to reallocate those points, and it says that it will be left up to 2019 rulemaking. But interestingly enough, if we go to the receive and kind of receive and incorporate the Health Information Exchange measure, they've already determined that those 20 points will be reallocated oddly to the first portion, so the ability to send it out. So you would have 40 for just sending out information, so like your continuity of care document. So they've kind of taken that concept and applied it to the individual objectives and measures within TI. It's kind of an interesting thing they've done there this year.
Yeah, thank you, Reed. That's helpful.
And you know, one other thing I might add, this provider to patient exchange, the component of that is basically we're kind of familiar with the view, download, and transmit through a PHR, personal health record, and that's pretty standard these days now. But what's new in the 2015 certified EHR technology is having an API kind of a technical term, application programming interface. But basically, you're opening up your EHR to other third-party applications, such as on an iPhone or a tablet or whatever, and allowing the patient to access their data and retrieve that. And so basically, that's one of the measures there. However, they have put in the specification sheet that if you're not able to implement that API technology in 2019, there is kind of a get-out-of-jail-free card for that one. So you still have to have that PHR view, download, and transmit, but if you can't do the API portion, you're not fully required in this year, and I expect that 2020 it will be required.
Yeah. So I'm going to go on to the slide 9 because you talked about the reweighting. So when something is just, for an example, when it is reweighted, you'll see in the calculation changes that first number in the score. So if your e-prescribing were reweighted to, let's say, to the Health Information Exchange, that would be 25 times the 0.73 there, just so that people visualize how the calculation changes. All right. Looks like we may have another question. That is. Quick question on the MedRec. Okay. In the HIE measure, the definition of the numerator is as follows. Numerator, the number of electronic summary of care records in the denominator for which the clinical information reconciliation is completed using CERT for the following 3 categories. And it's medication review of the patient's medication, including name, dosage, frequency, and route of each medication. Medication allergy review, patient's known medication, and current problem list review of the patient's current active diagnosis. Was the med reconciliation just moved to being part of the receiving, incorporating health information? My answer to that would probably be, if that's one way to look at it, because they're still having you do some of the same things that you would have done within the med reconciliation. And I don't know if Reed is still on or not, if you have anything to add to that.
Yeah, this is Reed. No, I would agree, Mona, with what you said there. They just kind of shifted that over and incorporated it. So when you're receiving like a CCD and it has those meds, med allergies, and problem lists, that you would have to do a reconciliation, but only for those that are being sent to you.
I think the spirit of the two are very similar. That would be my interpretation. James, is there anyone else in the call queue?
No, we have no questions.
Okay. All right. I'm not seeing anything else in chat. I'll give people a few more minutes to see if they want to either dial in. If I haven't answered the questions in chat in a way that people can understand, or if I've confused people, please feel free to use the phone to call in.
Mona, this is Reed again. While we're waiting, I might point out another interesting aspect of the PI category, specifically pertaining to the public health and clinical data exchange requirement to connect and report to an immunization registry or public health registry. So in later years, previous years, they had the concept of stating that if you were simply in contact and submitted intent to participate with a registry, or if you were doing testing, or if you were actually submitting data, one of those 3 components, that's considered being engaged with that registry, and you would get credit for that in 3 of those types of engagement with a registry, and that's true for 2019 as well. so they've carried that over again.
Okay, thank you. Are there any other questions?
Yes, we have a question from Darlene.
Okay, Darlene.
Hi, this is Darlene Sweater, and my question is for the first component of the HIE objective about spending our health information. I just wanted to confirm we would need to complete a reconciliation of a patient's medications, allergies, and problem list prior to sending that data in order for it to count in this measure. Is that correct?
That is my understanding. I've also have Reed and Elena on the line. Either of you agree or disagree?
You know, this is Reed. I believe that is only the second measure there, not the first one. However, what we said there is best practice. So if you're creating and compiling a CCD and sending that, so it's outbound, I don't believe in the measure itself that that is measured. It is only a component of that second when you're receiving and incorporating the information. But certainly, like I said, that's best practice. You want to be confident that the information you're sending out to whoever you're referring them to is accurate and has been reconciled. So while CMS doesn't measure it in the program that way, it certainly is a good practice.
Yeah.
Thank you.
Thanks, Reed. Any other questions?
No questions over the phone.
Wait a couple minutes. Just as a reminder for the questions, they do not have to relate to the specific information presented. This is an open office hours, so if there are any questions related to the quality payment program at all, feel free to ask those at this time. I'd be interested in knowing, and you can put this in the chat, if anybody, who out there has already reported in any issues you're having or any challenges with 2018 reporting. If you can put that in chat or dial in to share any experiences that you think might be helpful for those who haven't yet reported. Awful quiet group of reporting must be going very smoothly, and I know that the reporting portal, it works fairly well. And
excuse me, we have a question from Greg.
Okay, thanks.
Hi, this is Greg. What I'm looking at this year is CMS is trying to include a lot more providers. I think they've expanded. You know, we're kind of used to working with doctors pretty much. And I think they're trying to expand the number of and types of clinics that are coming in. Is that correct? You think that's right?
They're expanding the types of clinicians that are eligible for the quality payment program. But given with the expansion of the clinician types, they also added a low volume threshold measurement, which is the number of services. So I guess one way, yes, they're trying to include more. They're also trying to include a little bit more flexibility with the opt-in to the program so that those who maybe don't meet the low volume threshold, who would like to report and get a positive payment adjustment, have that opportunity to do so.
Okay, so my comment is there's probably a considerable number of potential clients out there that would like to participate, but they have no idea where to start.
True.
Like some of the offices I've been in, there a lot of providers, they're just trying to get, their work done for the day, let alone any extra program. So what I'm wondering is, you probably have more insight. You and Stratus probably have a lot more insight to this than I do. So I'm just kind of guessing here, but if there were a lot of clients out there, would it be good to put on a office hours of, here's an overall view of what you need to participate. If you're a small practice, you can meet the minimum number of patients and you would like to participate. Here's your overall view for the year. You need the risk analysis, you need business agreements, you need how to set up probably HIE or direct messaging, whatever they're using, how to do that. For instance, my direct messaging for one client, it took 6 months. From July to, I sent a thank you note out in January, and I know there was only 20 minutes worth of work really involved in that, even though it took 6 months. But anyway, the point is, would you like to publish something about, if you're new to the quality payment program, or if you'd like to participate, here's what you need. Here's your starting point.
I think that's a great suggestion, and Lake Superior Quinn can probably put something like that together. Sounds like a great topic that we could run for the office hours, or maybe a separate webinar. For our office hours, we're really trying to have the didactic session maybe about 15 minutes and then move right into question and answer so that people can ask their questions. But I think that's a great suggestion, Greg.
Well, they're not going to know it unless somebody is more experienced here than me and, knows better than what I'm saying. I guess feel free to speak up. But from my experience in working with some of the practices and so forth, you have people out there that are really busy during the day and so forth. They would like to participate, but they don't know where to start. For instance, if you have a website and you want your doctor, you want to be able to contact your doctor through his website and an email, you need a business agreement with that web developer.
Mm-hmm. Okay.
And there's some issues, things like that with sending PHI. There's the rule, some people are saying, well, people won't do that. You say, well, yes, they will. But you have to do it properly. So there's things like that that might help.
Okay. Yeah, thank you for the suggestion.
And this is Reed at Stratus Health. I might add to that. We have recognized that especially the smaller offices need some extra hand-holding. And I know our partners in Michigan and Wisconsin, so Stratus covers the state of Minnesota for our Lake Superior Quality Innovation Network. We actually did calling to do outreach to clinics of 15 or fewer providers, and we've kind of upped our contact rate to the high 90% to make them, number one, aware of the program, and then also we're funded through CMS, just like we're doing our educational office hours here, to provide that sort of assistance to guide them through what are the steps that I need to take to onboard to the MIPS program. So what do we need to consider from an eligibility perspective? And Mona was describing these new thresholds due to 90,000 of Medicare allowable charges, or 200 Medicare beneficiaries, or the 200 professional services. And I need to correct myself, it's and. If you're doing all three of those, you're considered eligible, but there's also the opt-in. If you do 1, 2 of those, you can participate on a voluntary basis. So what we do is we kind of put our information out there, doing some outreach calls. They can contact us. There's some links on this slide deck too. They can contact Candy directly, or we have an email address, qpphealth@stratushealth, STRATIS health.org, and we've onboarded a number of new clinics and walked them through, like, what are the basics, what do I need to do? And I think we, Mona, did you cover those newly eligible types of
Yes.
providers?
Yes, we did.
Right. So,
yeah.
right.
And yeah. Reed, thank you for reminding me the outreach calls, because that's been no small feat for all of our states to do those outreach calls to all the small clinics that may or may not have an individual in their clinic that devotes their time to this. So I do. Oh, go ahead.
If they have any EHR, some of the EHR companies provide support, but sometimes the support may not be quite as complete as they would really be needing to successfully attest at the end of the year. That's been some of my experience now.
Yeah.
Like I said, your strategist probably gets a lot more feedback on this than I do, so they're probably taking the lead on this one. Okay.
Yeah, great. I would add to my comments that it really is on a case-by-case basis, and it is truly, like you said, dependent upon your EHR vendor and how much assistance they're providing you. Additionally, when we get into specialists, there are those associations that often have good MIPS guidance and materials put together. So if you're a member of an association, that's another avenue that you can connect with and get some MIPS guidance for onboarding and participating.
Okay. So maybe my idea is already taken care of then or something.
Yeah. We do, yeah, we're doing some of it, but I do like the idea of possibly a future webinar.
Okay.
I did have somebody comment on the reporting process, and they're receiving some errors for uploading their vendor reports into the website, and they had the same issue last year. I know that I worked with a couple of clinics that had that, and working between the vendor and the QPP help desk, and also don't be afraid to reach out to the folks that are listed here on this slide from whatever state you're from. We can maybe point you in the right direction.
Yes, I would add to that, Mona, from our perspective, we had that last year during the reporting period that when people would submit their data, they would get an error, but often it was due to the file formatting, so kind of technical aspects of the file, not necessarily the data that they were submitting. This is how it was compiled in an XML, kind of a technical extension, or a JSON, another kind of technical file extension name that they were using to submit the data.
Thanks, Reed. And one other thing I'd add to that, now I don't know if we'll get this year, but last year CMS did send us an error report and we reached out to clinicians that were on that report to say, hey, might be something wrong with your reporting. Now, hopefully we'll get that this year, and we'll be able to kind of watch for those things proactively.
And also I would add to it, Mona, you'd mentioned that CMS had made some leaps and bounds in their reporting website. So we did see kind of a sneak preview a number of weeks ago of what that looked like. And there is a kind of confirmational, I think it was some sort of green indicator where there was a button or something that the file had uploaded successfully or not. So you don't have to kind of wonder, did it work or did it not work?
Right.
So you'll know right away. It kind of validates the file itself when you upload it.
Mm-hmm. Okay. Any other questions on the phone?
No questions, but Lisa Gaw has just dialed in.
Okay. Hi, Lisa.
Hi. Kind of jumping in a little late, but thought I'd catch the last few minutes.
All right. All right. I do not have any other questions in chat either. Again, if you have any other things to share with folks that on the reporting, if you've reported already and encountered any issues or anything that you think might be of benefit to other people on the call, feel free to put it in chat or dial in. Okay, I did just receive another question. It says, this year we will be part of an ACO. It is my understanding that we will still need to attest for the TIN for the ACI and IA category. So the ACI is changed to PI, and it depends on what type of ACO you're with. If you're a Track 1 shared savings, then you may have to report. You'll probably need to report the PI, but not the IA to my what I'm understanding. Lisa, maybe you can add to that. You know, if you're still on. If you're talking, you might be on mute.
Sorry. Yep. So yeah, it depends. You need to really check. You know, I think specifically if the improvement IA category, your MSSP or your API. No, what do I want to say? Your ACO should report for your improvement activities because each one of those gets scored specifically based on their contract. But if you are getting a low improvement activity score because you're only getting 20 out of 40 points, you can still report additional improvement activities. I'm not sure if anybody's had to do that, though.
Right. And this particular person is from Wisconsin. Feel free to give me a call and I can look it up based on your specific ACO. We can try to work through it together. Because each ACO is a little bit different, depending on the track.
But you do definitely need to report your PI, promoting interoperability category.
And this is Reed at Stratus Health. Just for the benefit, because Greg brought up the fact that there may be, new participants interested in the program, and if we have anybody on the call, we just had a whole bunch of acronyms that kind of probably peppered your eardrums just to decipher those. ACI is Advancing Care Information, which was the prior name of the Promoting Interoperability category, one of the 4 categories in this. ACO is Accountable Care Organization, MSSP, Medicare Shared Savings Program, and within that program they have ACOs, which are identified as Alternative Payment Models, APMs. So there's a lot of acronyms out there that are coming at
Yeah, thanks, Reed. I didn't realize we had some new participants. Thanks.
Yeah, you just never know. And Reed, thanks for keeping us honest.
Sure, no problem.
So I do have one other just question, and I don't necessarily have an answer, and I don't think the person is looking for a definitive answer. But does anyone think the current government shutdown is going to affect the CMS and the support we may need when submitting? At this point, we have no knowledge of that any effect on that. But again, you just never know.
And this is Lisa. I was on a call with some of our leadership yesterday, and CMS is not affected. That is not affected. The CMS department is not affected by the shutdown. They're exempt.
Yeah. Currently, yep. Okay. Any other questions?
Nothing over the phone.
All right. It's about 10 minutes to, so I think we'll wrap it up if there are no other questions. So thanks again for joining us today. Unless any of our panelists have anything else to add before I close this.
Not at all.
Hearing any? Okay. All right. Thanks again for joining us. As mentioned on the onset, we'll compile and vet the questions posed today and email you the answers, or contact you directly if it was something more specific. And please remember, when you close out of this, you'll be directed right to a survey. Please take a minute and just fill that out. Your feedback is very much appreciated. With that, we will end the call. Thank you.
Thank you, ladies and gentlemen. This concludes our today's conference. Thank you for participating. You may now disconnect.